Katerina, Sophia, and Nikos. I'm honored with the invitation, and it's always a pleasure to be here with you and with you as well. And let me start by saying that, yes, I'm going indeed to be an ex-ERS president, but this is also due to the fact that I have an excellent mentors, Mina and Nikos. You have to admit, you have a part in this, so I very much appreciate this friendship. So now, lung cancer screening. I must say that I am very happy because Mina provided me with a wonderful introduction. Indeed, I am not including, I'm sorry, so for some reasons my slide is not displaying correctly, so you have just the outcome of the Nelson trial that Mina mentioned. Unfortunately, the figure is not displaying properly, whatever. The important part is here, so 10 years of the follow-up. And the Nelson, as Mina stated, is the best trial we have even now, although it was published in 2020 and started in 2010. Because Nelson was the first to introduce a proper protocol, and importantly, the control group was actually not controlled by any pre-planned diagnostics. So those were people that just lived their lives as they would be anyways, whereas the intervention group underwent the low-dose CT screening at prescribed intervals. And this is what happened is that the study demonstrated a significant reduction in now it's good. Significant reduction in mortality due to lung cancer in a total group by 24%, but as you can see in females, it was by 33%. And also importantly, Nelson applied a volumetry to follow up the nodules. So not just as in American study, the diameter of the nodule, but they introduced for the very first time the assessment of the volume of the nodule, which proved to be much more sensitive. So this is what we based on. And importantly, they showed really the change in the diagnostic pattern. So many more patients with early lung cancer have been diagnosed. As you can see here, almost 60% of diagnosed patients were in stage 1, whereas in the control group, more than 60% were diagnosed with advanced lung cancer. So that makes the difference, and I think I don't have to explain why it is so important. Just let me remind you that lung cancer is actually the major killer in terms of oncology-related deaths in Europe, both in women and in men. So, and this is an epidemic that we will have to measure up in incoming years in Europe, not only in Greece. Of course, smoking is an issue, and I would like to fully emphasize the importance of a smoking cessation program coming together with the low-dose CT scanning, because I don't really imagine that it could be any other way. We need to link primary and secondary prevention together. The quality of the smoking cessation advice within the screening program throughout Europe, I would say, is something that we really have to look at very carefully, because I don't believe this is done as it could be done. However, the importance of lung cancer screening per se has been identified some time ago by the respiratory community in Europe. Mina has cited a number of publications, but I'm just showing the major ones, starting from this very important statement published by European Respiratory Society and European Society of Radiology in 2020. That was the time when we started to advocate for lung cancer screening in Europe, in the European Commission, European Parliament, We have already had the data showing that effectiveness of lung cancer screening with low-dose CT is equal, if not better, in comparison to other commonly accepted screening programs in oncology. And having said that, we were quite surprised to face a very strong and I would say sometimes quite aggressive opposition within the parliament, for example, that was opposing introduction of or suggesting a lung cancer screening as a next step in the cancer prevention, secondary prevention programs in Europe. The success was due to the fact that we really stood very strong. Other societies, medical societies and patient organizations supported us. So lung cancer screening was introduced into the parliamentary recommendation and then also Commission accepted lung cancer screening as the candidate screening in Europe. But then we have been, and this is the publication that directly followed this decision of the European Commission. Again, as you can see, joint publication by ERS and ESR. Very importantly, because for the successful lung cancer screening program, we need many more specialties that just pulmonary specialists, although, as I'm hoping to prove, we are actually key ones in this program. We, of course, need radiologists, thoracic surgeons, oncologists at some stage, and also GPs, very importantly. So this is the statement, but then a number of guidelines of standards have followed. Very importantly, again, Mina, I think, mentioned quite strongly that the lung cancer screening is not just any other chest scanning. This is pre-structured, labor-intensive, quality-demanding program that involves patients, GPs, pulmonologists, radiologists, centers, and then the follow-up, so the patient compliance is very important. Otherwise, it would not be a program. So this is the publication that really describes all those technical issues, also addresses the aspects of the qualitative assessment by radiologists. I very much support the statement that we need an expert center because Langrats and other criteria that are applied to low-dose CT are just quite specific. So it's not enough to have an experience in CT assessment. And radiologist who is involved with the screening needs to be experienced in specifically in assessing low-dose CT. And this is quite important. Just to give you an example, the Ontario province in Canada, for them took a year to make sure that they validated all the radiology centers that have to be proposed to become an expert centers for the lung cancer screening program in this province, a year. So this is not really easy. It could not be a random just assignment. And a very important, which I very shortly hope to prove to you, guideline on incidental findings. Again, this is not only a medical clinical issue, it seems to be unfortunately becoming a political issue because now we understand that there is a lot of information that we can retrieve or get from the low-dose CT scanning, not just nodules, of course, very important. This is why it started, but there is much more. And this is just a list provided by the guidelines. So I'm just mentioning it. But importantly for us, we can look for emphysema. Mina already showed that almost 45% of Greek patients demonstrated with emphysema. Just remember the criteria, high-risk population, not only for lung cancer, but also any smoking-related disease. That would include, of course, COPD and emphysema, but also interstitial lung abnormalities, bronchiectasis. Just three major. And for that, of course, the smoking cessation program and spirometry, I included a question mark because we do not have much experience with that. The programs have already started and are ongoing, so we will have some data soon. But the data for Greek population actually fit very well into this, into the data coming from this meta-analysis. You can see data coming from 42 screening programs in total, more than 125,000 individuals, and the prevalence of emphysema was 45%. At least 1/3 of those were presented with moderate to severe emphysema, and then airflow limitation in 40% of individuals, again moderate to very severe in more than half of this population. And as you can see, 65% of patients with airflow limitation had no idea they have a respiratory issue. They were never diagnosed before. So the lung cancer screening, or I would rather name it chest screening, provides a great opportunity to really also push for earlier diagnostics of airway obstruction. And the same is true for the coronary calcification. So better diagnostics of coronary disease. You can see we can clearly identify those patients. And Hansa study, the German study, clearly showed that the rate of calcification that could be calculated directly relates to the risk of acute coronary incidents in those patients. So having said that, I just want to quite shortly show what we have been doing in Europe. And directly after the decision of introducing lung cancer as the candidate for the screening in Europe, the Commission opened the call for a pan-European consortium project, and ERS, together with ESR, European Society of Radiology, joined forces. We produced an application and were successful to get the funding for this very impressive consortium. As you can see, 37 partners in 15 countries, and that includes a number of active pilot studies. I am co-chairing this project on behalf of the ERS. There is a colleague co-chairing this project on behalf of ESR. So again, a great example of multidisciplinary efforts. This is the map, and importantly, it's not only those two societies, but we have support from other medical societies, namely European Society of Thoracic Surgeons, of radiotherapy and oncology, and patient organizations. This is extremely important because we not aim to start the screening or prove the efficacy of screening. We want to really identify the potential obstacles and offer the solutions to improve efficacy of the lung cancer screening in Europe. And as you know, we have a very diverse situation in Europe, not only in terms of epidemiology, but also, quite importantly, in terms of healthcare provision, structure of the healthcare, but also cultural differences. This is what we want to do. We need or want to assess the needs and analyze the gaps, but also provide with the national experts the solutions. All that will be published on the dedicated website. We will provide you with a sort of a knowledge hub that would be accessible to anyone interested in lung cancer. But importantly, we also aim to target the populations that have been identified as the population of unmet need, and specifically women, because in number of European countries, actually the enrollment of women was significantly lower than men. However, as you might remember from the Nelson, the effectiveness of lung cancer screening seemed to be higher in this population, female population, than hard to reach individuals. and high-risk population. So this is the map. As you can see, in green, there are countries with ongoing national screening programs, Poland, Czechia, Croatia, and UK. And in some countries, there are only pilots ongoing or even no efforts in terms of lung cancer screening. So some preliminary data. So this is the work package addressing the hard-to-reach population. What I would like to point or address your attention to is that we not only address the social deprived population, but also ethnic minorities, hard-to-reach population in terms of geography. I think this is very true for Greece as well. So those who live far from the university, academic, or even bigger city, those hospital centers that could offer the stationary screening. And then also occupational medicine. And you can notice that we were quite successful in terms of socially deprived. In yellow, you can see we overachieved. And in terms of remote population, but quite unsuccessful in terms of ethnic minorities. That has proven to be very difficult to reach, but also occupational medicine. In terms of high-risk population, and this is important since I'm speaking to the respiratory specialists, so we have identified the high-risk population in terms of the diagnostics of COPD and ILD. You know that both groups, both diseases are linked to the high risk of lung cancer, independently of the smoking history. And as you can see, we were not able to ensure a good enrollment of those two groups. The question is why? We are currently working on understanding the reasons for that, but definitely it also points to the fact that we need to increase the awareness of the lung cancer screening among the respiratory clinicians. And finally, just 2 slides about Poland, because in Poland we have a history of active lung cancer screening pilots for years. In 2023, we just completed nationwide lung cancer screening pilot that just covered the whole country, but it was done in a stationary manner, so just bigger cities. So you can see here on the map in the middle, it's a map of Poland, and we have identified this eastern region to do the mobile screening, because in the past efforts, they actually enrolled 0 patients, no patient enrolled by the stationary lung cancer screening program. Quite surprising. Well, in a way, because this is very conservative rural region, and so we decided to start the lung cancer screening program with the mobile city center with some locations that are pointed here. And within 8 weeks, we were able to enroll more than 2,600 patients or individuals. That was due to the fact that we actually started a very intense, very active campaign. I'm not going to go into details, but face-to-face meeting, posters, leaflets, TV and radio programs, and quite importantly, we also were very happy to have support and collaboration from the church. And I must say, I don't have data for that. That's just my impression. But those locations where the information about screening was also provided by the local parishes were very, very successful. So just to speak for the fact that you need a lot of cooperation from the local community in order to be successful. We, as of end of the May, we identified 22 patients with lung cancer, 1 lymphoma and 1 breast cancer. But the important part is here. Only 4.5 individuals self-declared COPD. And as you can see, 2.8 self-declared the lung fibrosis. And another interesting fact, although we address the hard-to-reach population, the remote location, you can see that almost 20% of participants made an effort to drive by car more than 30 minutes to the location of mobile units. And this fulfills the definition of, again, remote. So they came specifically to this remote unit. So again, the need that needs to be fulfilled. So final thoughts. I hope within this very short time, I was able to show you that low-dose CT screening is not just a lung cancer screening, and specifically in Poland, we advertised it by check your lungs health, not a lung cancer screening, and I think this is more appropriate name. So it's lung cancer, COPD, or emphysema, and cardiovascular diseases. We have a very complex situation in Europe at the moment. There are many needs that are unmet, many problems also financial that have to be discussed and met. But more importantly, we need to emphasize that us, the respiratory community, needs to play a key role in those efforts, because we actually provide healthcare for population at risk. You can think about your patients. I'm quite sure that many of them fulfill the inclusion criteria. We are the prime stakeholders in smoking cessation provision. We have the expertise not only to identify the candidates, but then provide the proper diagnostics for them. And we also would be anyways responsible for the surveillance of the individuals, not the patients, but individuals who are enrolled into this program. So we are also following the path of the SOLACE, not only within this consortium, but I listed here a number of projects that are part of the Europe Beating Cancer Plan, where the respiratory community plays a leading role in the field of lung cancer. And I strongly believe this is as it needs to be, because we should not accept the situation where we are actually isolated and not allowed to take part in caring for our patients with lung cancer. Thank you very much.